ABO blood group system. The ABO blood group system is one of the most fundamental classifications in transfusion medicine. It is based on the presence or absence of specific antigens on the surface of red blood cells, which are defined by unique sugar molecules. Antigens and genetic pathways. ABO antigens are determined by the immunodominant sugar present on the cell surface. The genetic pathway begins with a precursor substance, which is influenced by the H gene. If the H substance is present, it can be modified by the A gene to produce A and H antigens, or by the B gene to produce B and H antigens. However, in individuals who lack the H gene, a condition known as Bombay phenotype or O, the precursor substance cannot be converted, resulting in the absence of A, B, and H antigens. The ABO genes themselves determine whether a person expresses A, B, AB, or O blood type, depending on which enzymes are produced to modify the H substance. Subgroups of blood type A. Blood type A is further divided into subgroups, the most common being A1 and A2. These subgroups differ in their serological reactivity with a reagent called anti-A1, which is derived from Dolichos biflorus, a type of plant lectin. Lectins are plant or seed extracts that are diluted to agglutinate specific human blood group antigens. A1 cells react positively with anti-A1 and are agglutinated. A2 cells do not react and are not agglutinated. Other subgroups, such as A3 and AX, contain less A antigen and more H antigen, making them weaker in expression and more difficult to detect. The interplay of ABO, H, Secretor, and Lewis systems in blood typing blood group classification is more complex than just AB, AB, or O. It involves a network of genetic interactions among the ABO, H, Secretor, and Lewis systems. These systems influence not only the antigens present on red blood cells, but also those found in body fluids. The H gene and the Bombay phenotype. The H gene is essential for the expression of A and B antigens. Individuals who lack this gene, genetically classified as lower HH, exhibit the Bombay phenotype, also known as O. In these individuals, the precursor substance cannot be converted into A or B antigens due to the absence of H, resulting in a blood type that appears as group O but lacks the H antigen. For those with at least one functional H gene, either capital homozygous HH or the heterozygous HH, the H substance serves as a foundation for the attachment of A and B sugars. The amount of H antigen varies across blood types. Group O has the highest amount of H antigen. Group A2 has slightly less. Group B follows. Group A2B has even less. Group A1 and Group A1B have progressively lower levels. Bombay phenotype. O has none. To detect the presence of H antigen, a reagent called anti-H lectin, derived from Ulex europaeus, is used. This lectin will not agglutinate cells from individuals with the Bombay phenotype, but it will agglutinate cells from Group O individuals who possess the H gene. The secretor gene. The secretor gene, abbreviated as SE, enables the expression of A, B, H, and Lewis B antigens in body fluids such as saliva. Individuals with this gene can secrete these antigens into their fluids, providing additional clues for blood typing and genetic analysis. The Lewis system. Lewis antigens are unique in that they are plasma antigens that adsorb onto red blood cells as a person matures. Their expression depends on the presence of H, SE, and LE genes. An individual who has H and LE genes but lacks the SE gene will express H and Lewis A on their red cells and in their saliva. The presence of Lewis A in saliva does not require the SE gene, but the expression of Lewis B does. An individual who possesses H, SE, and LE genes will express H and Lewis B on their red cells and will have H, Lewis B, and reduced levels of Lewis A in their body fluids. ABO blood typing. Blood typing within the ABO system involves two complementary approaches. Cell typing, also known as forward or front typing, and serum typing, also referred to as reverse typing. These methods help determine an individual's blood type by identifying the presence or absence of specific antigens and antibodies. Cell typing, forward typing, by tube method. In forward typing, the goal is to detect antigens on the surface of red blood cells. This method uses reagent anti-A and anti-B antibodies, and the testing is conducted at room temperature. The procedure involves mixing unknown red cells with the reagent anti-sera. If no agglutination occurs, it means the red cells do not have the antigen that corresponds to the reagent antibody. If agglutination occurs, it indicates that the red cells do possess the antigen that matches the reagent antibody. This method helps identify whether the red cells carry A, B, both, or neither antigens. Serum typing, reverse typing. Reverse typing focuses on detecting antibodies in the serum. It is also performed at room temperature, using saline suspended red cells from known group A1 and group B donors. However, the optimal reactivity of serum antibodies, specifically anti-A and anti-B, occurs at 4 degrees Celsius. In this method, if no agglutination occurs when unknown serum is mixed with reagent red cells, it means the serum lacks antibodies against the antigens present on the red cells. If agglutination occurs, it indicates that the serum contains antibodies that react with the antigens on the reagent red cells. Together, forward and reverse typing provide a reliable and accurate determination of a person's ABO blood group. Resolving discrepancies in ABO blood grouping. ABO blood typing is a critical step in transfusion medicine, but discrepancies can arise due to various factors affecting either the red cells or the serum. Understanding these issues and applying appropriate resolution techniques ensures accurate blood group determination and safe transfusion practices. Red cell-related discrepancies. First, rouleau formation, due to improper washing. When red cells are not adequately washed, they may form rouleaux, stacks resembling coins, which can interfere with agglutination results. Resolution. Repeat the test using saline-washed cells to eliminate excess proteins and improve accuracy. 2. Mixed cell populations from transfusion. A patient who has received a transfusion of group A or B cells mixed with group O cells may show inconsistent typing results. Resolution. Review the patient's transfusion history to identify recent transfusions that could explain the mixture. Third, subgroups of blood type A. Individuals with the A2 subgroup may or may not produce anti-A1 antibodies, leading to unexpected reactions. Resolution. Perform testing with anti-A1 reagent to identify and confirm subgroup status. 4. Unusual genotypes, such as Bombay phenotype. The Bombay phenotype lacks the H antigen, which is essential for expressing A and B antigens. These individuals may appear as group O but have unique serological behavior. Resolution. A. Use anti-H reagent to test for the absence of H antigen. Bombay cells will not agglutinate with anti-HB. Bombay serum will agglutinate cells from groups A, B, and O, including group O screening cells. C. Further identification may be needed, but is beyond the scope of routine testing. 5. Disease-related changes in antigen expression. Conditions such as leukemia or bacterial infections can alter red cell antigens, leading to phenomena like acquired B antigen expression. Resolution. Evaluate the patient's diagnosis to determine if disease processes are affecting blood group expression. Serum-related discrepancies. Premier rouleau, due to elevated serum proteins. Disorders such as Waldenstrom's macroglobulinemia or multiple myeloma can increase serum proteins, causing rouleau formation. Resolution. Use saline replacement to remove excess proteins and clarify agglutination results. 2. Cold or room temperature antibodies. Antibodies such as anti-H, anti-I, anti-M, anti-N, anti-P1, or anti-Lewis may react with reverse typing cells at cooler temperatures. This includes anti-A1 in individuals with A2 or A2B blood types. Resolution. Perform a mini cold screen or panel, testing at lower temperatures to identify cold-reactive antibodies. 3. Age-related antibody deficiency. In elderly individuals, antibody production may decline, while newborns may not yet produce sufficient antibodies. This can result in missing expected reactions. Resolution. A. Check the patient's age. B. Use a mini cold panel to enhance detection of weak or missing antibodies. 4. Compromised immune function. Patients with conditions like hypogammaglobulinemia may have reduced antibody levels, affecting serum typing. Resolution. A. Review the patient's medical history. B. A mini cold panel may help detect low-level antibodies. General guideline for discrepancies. Until any ABO discrepancy is fully resolved, Group O red blood cells, which lack A and B antigens, should be used for transfusion to ensure safety. The mini cold panel. In blood typing, particularly within the ABO system, there are instances when expected antibody reactions do not appear during standard testing at room temperature. The mini cold panel is a specialized technique designed to address this issue. This method serves two important purposes. 1. It helps enhance the detection of anti-A and anti-B antibodies in a patient's serum when these antibodies are expected but not demonstrable at room temperature. By lowering the testing temperature, the reactivity of these antibodies can be improved, making them easier to identify. 2. It also aids in identifying cold reactive antibodies, those that respond to antigens at cooler temperatures. These antibodies may react with antigens found on Group A1 and Group B reagent red cells, and their presence can complicate reverse typing results. By using the mini cold panel, laboratory professionals can more accurately interpret ABO discrepancies and ensure safe transfusion practices, especially in cases involving weak or missing antibody reactions. Saline replacement. In blood banking and immunohematology, accurate interpretation of red cell reactions is essential. One common challenge is differentiating rouleau formation from true agglutination. Rouleau refers to red blood cells stacking together in a formation that resembles a pile of coins, which can mimic agglutination under the microscope. To resolve this, the saline replacement technique is used. In this method, the serum in the test mixture is replaced with saline solution. If the observed cell clumping is due to rouleau, the cells will dissociate once the serum is removed and replaced with saline. This confirms that the reaction was not due to antigen-antibody binding, but rather to increased protein content in the serum. Understanding the patient's clinical diagnosis and the composition of their serum proteins is crucial in interpreting rouleau. This phenomenon is commonly associated with conditions such as multiple myeloma and Waldenstrom's macroglobulinemia, both of which are characterized by elevated levels of serum proteins that promote rouleau formation.